Thank you, Sujit. Thank you, Balaji sir and team Ozone for giving me this opportunity on this day. I'll take you through a journey of a liver transplantation, what we actually do in the operation theatre. The agenda will be preoperative evaluation, preparation of OT for liver transplantation, induction and maintenance, intraoperative management of anesthesia for liver transplant, and what we actually do when we go through the different phases of surgery. So let's go to a case. He is a 50 years old male, height is 161 centimeter, weight is 66, BMI 25.5. Diagnosis alcoholic decompensated chronic liver disease, decompensation in the form of ascites. He had history of ascites, he had history of HRS in October 2002. OGD was done, banding was done. So now you have all sort of decompensation. You have a GI bleed, you have a HRS, you have ascites. And you have to manage all these three when you're thinking of giving fitness or anesthesia to this patient. Coming to the lab investigation, HB 8.9, fairly acceptable. INR 2.12, still very acceptable, which was more than 9.78 way back in month of July. So now he's maintaining INR of 2.12 with his plan to undergo liver transplantation. Creatinine is 1.8, which was a bit concern for us, but with the background of ascites, HRS, we can't avoid this patient for anesthesia, so we have decided to take him for surgery with a creat of 1.8. Lab parameters LFT fairly okay, albumin 2.4, which indirectly tells you what amount of fluid you should give and which amount of fluid you should give intraoperatively. Triple H negative, direct Coombs test positive, which was informed to the blood bank and cross-matching was done according to that. This is all routine investigation we do when we post a patient for liver transplantation. These are the must invitation because if suppose the cadaver donor is there or a living donor is there, CMV, IgG positive for both patients are safe. But the recipient is negative and donor is positive, the high chances that the recipient might get CMV infection in post-operative period. So getting this lab investigation is must when you're planning the patient for a liver transplantation or kidney transplantation. So coming to MELD sodium, which is 28. Now, why MELD sodium is being calculated? If your MELD sodium is more than 15, it predicts a high mortality if the patient undergo a liver transplantation in next 3 months. As the MELD score increases, the mortality chances increases in the first 3 months. Now this MELD is 28, he have a probability of death of almost 60 to 70% in next 3 months if he doesn't undergo a liver transplantation. So MELD indirectly tells you the prognosis or mortality indicator of the patient who are not undergoing liver transplantation and continue with ICU management or medical management. CTP12C, again, C is indication for liver transplantation. So anywhere when you're thinking of a liver transplantation or you're thinking of any patient who had liver cirrhosis undergoing any other surgery like orthopedic or any abdominal surgery or hernia surgery or anything, calculate the MELD score and calculate CTP score. That indirectly tells you what are the chances of mortality. Anesthesia per se is an independent mortality predictor in patient who had a decompensated liver disease because the surgical stress or anesthesia stress increases post-op chances of hepatic encephalopathy. 2D echo is fairly okay. These are the two things we do routinely for liver transplant patient. Dobutamine echo, where the patient is not able to do a 6 minutes walk test or a modified stress test. So we give a gradual increasing doses of dobutamine to see the effect of dobutamine on heart, which is increasing in the ejection fraction, which is fairly okay. Bubble contrast study is done to see the shunts, intracardiac versus pulmonary shunt. If you inject saline with air bubbles, and if you see the air bubbles in the left side of heart within 4 beats, that is intracardiac. And if you see the bubbles after 5 to 6 beats, that's pulmonary shunt. Pulmonary shunts are more troublesome in any patient than the intracardiac shunt. These are the routine tests we go ahead with before going any patient for a liver transplantation. Angiography only if the age is more than 50 and patient is being diagnosed diabetic patient. Right heart study, where we think the pulmonary hypertension, systolic hypertension is more than 45. Then we go for a right heart study and see what is the exact measure of right pulmonary hypertension, which will trouble us post-operatively in weaning the patient from ventilator. Pulmonary function test was done. That was fairly okay. Generally, these people have a restrictive lung pattern because of sarcopenia, ascites, not able to breathe easily, weakness and all these things. So restrictive pattern will be fine in all this patient. CTPNS was normal. HRCT routinely done. Now, COVID wise, we are doing HRCT as well as rapid antigen. CT scan chest was fairly okay, not to worry. So when your patient have an end-stage liver disease and this patient comes to you for a routine surgery, things to be noted from respiratory point of view for all of us is hepatopulmonary syndrome. That's been diagnosed when you do a ABG on room air and we see a very low PO2. No significant treatment available for this. Transplantation is the only treatment. But if suppose you want to give anesthesia for a non-transplant case, be aware, be careful. The patient will be hypoxic for a long time and this patient will improve hypoxia when you make it supine. The moment patient is in a propped up position, they will hypoxic, but when they are in supine, they will be improved oxygenation. Portopulmonary hypertension generally resolves anything more than 45 is a portopulmonary hypertension where pulmonary arterial systolic pressure will be very high. This will be resolved only after transplantation because it's almost like a volume overload status. Hepatic hydrothorax, like a pleural effusion, should be drained only when patient is having symptoms. If the patient is asymptomatic, avoid touching pleural effusion or ascitic fluid. Hepatorenal syndrome is a form of decompensation where creatinine goes up by 0.3 within a week. Suppose today creat is 1 and after 3 days you do a creat, it's 1.3. So indirectly there is a rise of 0.3 and that indicates that the patient is landing up in HRS, which is easily reversible with terlipressin or fluid challenges. Esophageal varices, a routine checkscopy can be done if the patient is posted for a major surgery. Minimum 3 months prior, a checkscopy has to be done if the patient is planned for elective liver transplantation. Hepatic encephalopathy, very commonly seen. Deranged coagulation profile, don't treat it unless and until you document some visible bleed like upper or lower GI bleed, or sometimes if you are planning to do an invasive procedure like ICDs or central lines, the central lines we don't recommend to put to correct the coagulopathy like giving FFP or cryo till you have bleeding. Hyperdynamic circulation and a vasoplegic syndrome. Everybody has to understand this patient who is cirrhotic and he has a decompensation in form of HRS or ascites are vasoplegic. That means they have a very low SVR. So if suppose you see a BP of 80 systolic, instead of giving them large amount of fluid, always prefer giving them noradrenaline infusion, because you give fluid, the BP will increase for 5 minutes, but after 5 minutes again BP will fall down and is not going to increase. So always liver cirrhotic with decompensation, prefer noradrenaline over fluid when you are treating either in ICU or in operation theatre. So these products was released 15 units of packed red blood cells like PCV, 15 FFP, 10 RDP, 10 cryoprecipitate, and transfusion trigger was if HB less than 8. Coming to the intraoperative management, syringes for induction, what we keep is glycopyrrolate along with fentanyl. For recipient, we give almost 500 mics of fentanyl and we doesn't continue any infusion during the surgery. Morphine, yes, definitely gives you a cardiostable condition. Almost 10 mg of morphine we give to this patient. Propofol, induction with propofol or dexmed or etomidate, fairly okay. When you give 500 mics of fentanyl, we don't require large amount of propofol to be infused. Choline is must, is recommended when you giving a anesthesia for a liver transplantation, because they are almost like a full stomach patient who have large amount of ascites. So gastric emptying is being delayed in this patient. So succinylcholine used in almost all the patients unless the potassium is more than 4. We avoid, but routine use of succinylcholine is recommended because of the large amount of ascites and delayed gastric emptying. Emergency drugs, atropine, we take 2 ampoules in a 2 cc syringe. Adrenaline, we have dilution 1 and dilution 2, that's 100 mics per ml. Phenylephrine, we have dilution 1 and 2, that is again 100 mics per ml. And ephedrine, we have 6 mg per cc or 3 mg per cc. We keep it ready always. We don't prepare syringes when it is required. When induction is being prepared, we have to keep the emergency drugs also ready because this patient might collapse anytime. Induction, propofol or etomidate, no issues. Fentanyl 500 mics bolus, rapid sequence intubation with succinil. Maintenance on atracurium infusion, we use propofol infusion because we have a good control of blood pressure in this situation. If the hypertension is profound, then we stop propofol infusion for time being and we shift to SIVO, and then we continue propofol as and when required. Fentanyl infusion, not very commonly in donors we do use fentanyl infusion, but recipient we have stopped using. Because of the large ascites they have, the nerve ending has been stretched. So they generally don't have any pain post-operative. I have hardly seen any patient who's been given analgesic post-operative in a recipient state. because of ascites and all these things, they have a very large abdomen and damage of the nerve ending. So generally, they don't complain of pain. Avoid nitrous oxide because it causes vasodilatation and increase in bleeding. So we are not using nitrous oxide in our operation theatre. Standard monitoring: 5-lead ECG, pulse oximeter, non-invasive blood pressure till we insert the arterial line, temperature nasal after induction of the case, ETCO2. Hemodynamic monitoring comes invasive blood pressure, central venous pressure line. Dynamic indices, I'll tell you, you people are all versed with cardiac situation. So cardiac output monitor, what we have is AV1000, which we are using in almost all the recipients. So we put two lines. What we require more number of ports to give infusions. So arterial catheterization will be a 20 gauge cannula, 4 centimeter or 6 centimeter in radial artery preferably. Avoid femoral because of the hygiene over a period of time. Post-operative, because of coagulopathy, many times we are not able to remove femoral line very soon. So use radial as far as possible. Two central line, one is 7 French triple lumen CVC catheter and other is 12 French SD catheter. Now, why SD catheter? Because there is large amount of hemodynamic instability shift during the surgery where you require large amount of IV fluids to be transfused to this patient. Now, giving a large amount of IV fluid through a 7 French triple lumen CVC becomes difficult many a times. Now, if you put a SD catheter, you have two lumens which are almost a big bore and you can give whatever amount of fluid in whatever amount of time stipulated. So this is our routine protocol. I started learning anesthesia in 2012 where they used to put 3 central lines and which has come down to 2 central lines now. One is dialysis catheter and another is simple triple lumen central line. USG guided, so we have avoided using any type of using blood products during central line insertion, whatever be the coagulopathy is. We use USG guidance that makes our life easy. This is a routine setup. Left side you see, the first top one is non-adrenaline, the second is calcium infusion, third is bicarb infusion. On the right side you see is propofol infusion, then comes your atracurium infusion, then comes your tranexamic acid infusion, and then the fourth syringe pump is terlipressin infusion if the patient have a very significant ascites. So this is the routine setup. You have standard anesthesia station here. We have ETCO2 monitor. I'll showing you the monitor picture also. So this is the routine preparation which is being used in almost 100% of cases. Terlipressin plus or minus if the patient have ascites or no. Hypothermia. This is Smith's level 1 warming machine which is connected to the IV line is must. Avoid hypothermia because hypothermia again precipitates coagulopathy. So we take precaution to avoid any sort of hypothermia. Temperature should be more than 35 ideally, because they use lot of amount of ice for the recipient while doing surgery. So temperature goes down to 34 also, but maintaining temperature anywhere before 35 is recommended and IV line is connected to this hotline warmer. This is rapid infuser level 1. This have a separate circuit available with it. It is used when the patient require large amount of IV fluids. The rate of transfusion through this fluid machine is 1200 ml per minute. This is called level 1. We have with us, but fortunately with improved techniques and improved surgical techniques, we are not using much, but these are the standard instrument kept in trauma units in most of the hospitals when they want to give large amount of fluid in a short duration of time through a large bore. You can't give it through a small bore, you have to give through a large bore. This is something called as a level 1. Now this is a cardiac output monitoring. You all might be well versed with this monitor because you are doing good number of cardiac cases also. You might be using some other technique, but what we are using here is AV1000, which is by Edwards. What we require is stroke volume variation. We have CVP here, we have SVR here, and we have a cardiac output here. So the picture in front of you is the best possible picture when you see a patient of liver transplantation undergoing after anesthesia. You have SVV 13, fair enough. You have SVR 891, cardiac output 5.4. These are the standard. We have done few cases where these gadgets were not available, but then it become difficult for you to manage this patient if suppose you don't have a parameter like fluid driven. You keep on giving fluid, saying the CVP and blood pressure, but at the end of the day, patient lands up in fluid overload, which should be avoided. So coming to the different cardiac monitors available in the market, I don't want to go in detail. What we use is FlowTrack followed by AV1000, but you might be using the different Lidco, Pico and all these things. They are basically pulse contour analysis, and then they give you information, but almost all the monitors have equal outputs and results. So what you are comfortable with, you should be using that. We use AV1000. Choice of fluid: avoid maximum fluid giving depending upon our routine calculation, insensible losses, and all these things. So choice of fluid will be 0.45 saline and the other balanced salt solution like plasmalate and kibelate. Why 0.45 saline is the jump of sodium? Because sodium is an independent predictor of mortality in post-op situations in liver transplantation. Suppose you have started sodium with 125, and after 4 hours of surgery, you have seen the sodium has jumped up to 135. That is a troublesome situation because a rapid correction of sodium leads to CPM and all these things. So 0.45 saline using and avoiding excessive increase in sodium is must. No ringer lactate because it contains lactate. Already the lactate is on the increasing trend, so avoid RL. Plasmalate and kibelate can be used alternatively, whatever available, because it's a balanced salt solution. As a colloid, if you want to increase the blood pressure, you have to use albumin. Now, albumin you have either 5% or 20%. 5% is not available in the market with us, 20% is available. We convert this 20% to 5% albumin by mixing it with a 400 ml of normal saline. We remove 100 ml, rest 400 ml, we put this albumin, so we make it 5% albumin. And this albumin can be used as a volume also and volume expander also. You have to do it in absolutely sterile situation to avoid any sort of infection. Starch, strictly no because of renal injury and coagulopathy. Is totally banned from almost all the setups. Starch has been banned now. Gelatin or Hemacil or Gelofusion is the alternative, but you have to be used with caution because it can have allergic reaction. Hemodynamic management: target mean pressure more than 65, fair enough. Non-epinephrine, vasopressin, not many times required, but if you require a second vasopressor, we are using vasopressin and acetamide. Dobutamine, dopamine, epinephrine, generally not needed where you try to manage with the cardiac output monitor. If required, some centers are using adrenaline, but dobutamine almost nobody is using. This is a ABG, a perfectly fair ABG where lactate is 1.7, sodium, potassium, everything is okay. We are happy, no acidosis. It's at the beginning of the case. Antibiotic prophylaxis: piperacillin, tazobactam, teicoplanin, and fluconazole. Metronidazole, few surgeons use. We have stopped using metronidazole because of not of much bowel handling in our situations. Now coming to the major phases, what we are doing during the surgery. First, a dissection phase where the surgeon is mobilizing the liver, dissecting the porta, dissecting the hepatic veins, and we are expecting more amount of bleeding. Then comes anhepatic phase where the liver is out of your body. Then comes reperfusion and then neohepatic phase. So what happened in dissection phases? The liver has been mobilized, liver has been lifted, liver has been dissected. So what you are expecting is lot amount of bleeding. If the patient is coagulopathic, you have more amount of bleeding in this situation. And what you have to do is do correction of coagulopathy. You can give, the choice will be first cryoprecipitate, then will be fresh frozen plasma, and then will be platelets. Avoid using large amount of platelets transfusion in this patient because this platelet will increase the chances of thrombosis in artery post-reperfusion. The given option, cryo will be best choice, and a tranexamic acid infusion continuously by 500 to 1 gram per hour will be helping you to prevent secondary fibrinolysis. Hemodynamic instability, very common. Drainage of ascites will lead to sudden shift of volume, so you have to be on toes to correct with albumin. We run a continuous infusion of albumin if the patient have a large amount of ascites till the end of surgery, either by a infusion pump, either by a bottle. 3 to 4 albumins over a period of time, 5 to 6 hours is fair enough. Coagulopathy, portal hypertension remains more important because you have the curtain which we put between the surgeon and us has to be quite lower down. So you have to keep on watching the surgical field, what exactly is happening there. If suppose surgeon is shouting, that means indirectly the patient is bleeding there. And if the surgeon is asking him to put some sounds, that means the situation is under control. So what we have to do is we have to keep peeping in the surgeon's field to see whether it's bleeding or not. Many times they are not ready to tell also that patient is bleeding. So what we have to do, we have to ourselves see if bleeding is there. If the bleeding is there, you have to ask them whether it is surgical bleed or whether it is a coagulopathic bleed. If it is coagulopathic bleed, then correct it with the coagulation products. But if it is surgical bleed, they will tell us and we have to ask them to correct it surgically or call for help if they are not able to correct it by themselves. Generally, this cirrhotic patient will have a severe coagulopathy, but we will never see a bleeding in this patient because there is decrease in both pro and anticoagulation factors. The only thing which will increase is von Willebrand factor and tumor necrosis factor. So talking about coagulation, though the coagulopathy INR of 4, 5, 6, you will see, but you will not see this patient bleeding because the anti and pro both are less in this situation. So avoid giving large amount of blood products if it is not indicated. TEG, I don't want to go in detail if TEG, this is a thromboelastography which is routinely done in all the patients who are cirrhotic and bleeding or during the surgery to see what exactly the patient requires. Now here in this figure, if you see R value, is 2.6, which is normal. Suppose if R value is abnormal, it's more than 8, that means patient will require cryoprecipitate. If the K value is more than 4, that means patient will require fresh frozen plasma. If the angle means this is the angle here, this is the angle here. That means the strength of clot formation. If it is less than 47, that means patient will require cryoprecipitate and platelets. If the MA, maximum amplitude means the thing it is going like this. If it's very low, if it is less than 54, then patient will require platelets. But this ought to be done only if patient is having significant bleeding. If the patient is not having bleeding, avoid using large amount of blood products. Thromboelastography is point of care, which is routinely used in all the ICU setups and where the patient of liver are being treated. Rotem is another version of TEG by another company, which gives you 4 results at a time, and it's a more comfortable compared to TEG. But we have TEG, so we are routinely using TEG in our situation. So I don't want to go in detail of this. This is TEG clot initiation, that is R. Clot kinetics, that's K value. Clot strength, that's MA. And clot stability, that's L by 30. Clot stability. So if anything derangement, you can see here also what exactly we do when you have deranged dysfunctions. So this indirectly tells you avoid large amount of blood products and give only if needed. TEG has become a point of care in all the patients, either hematology and liver transplant or liver ICU, where you see or expect a patient to bleed and you require to give blood collection. The another how to correct. Here see fibrinolysis. Fibrinolysis, when you see fibrinolysis, the only thing you have to treat is tranexamic acid. There is no other treatment for that. Or secondary fibrinolysis, secondary to DIC, where again you have to think of tranexamic acid. This is abnormal, like initiation of clot formation is very delayed here. And then there is a split here. So you have R value very high, K value is not available, angle is very low, MA is very low. So this patient needs correction only if he is bleeding. Fresh frozen plasma, what we have used is indication 10 to 12 ml per kg when you have a deranged TEG profile. Cryoprecipitate, very low fibrinogen on paper, or the patient is bleeding and you have a TEG and very low K value. Platelet is avoided as far as possible, but if the patient the TEG value is very deranged, you give RDP to avoid further complication of thrombosis. Transfusion strategies, don't want to go in detail. We have, I don't know whether it's Aurangabad is available. In many places, they have started making it available fibrinogen concentrate by Reliance and one other company called Intas, where they prepare fibrin concentrate, which is recommended 25 to 50 mg per kg. The cost goes up very high if you want to give it to the patient. Prothrombin complex we are not using, but hematological people are using nowadays for hemophilia and all this before surgery. Recombinant factor 7A we are not used because of its short half-life and rebound bleeding once the action goes off. These are the different TEG pictures which you can remember. If suppose you get such picture, then you have to give corrections as far as this figure shows. Coming to the anaphatic phase, challenges in during anaphatic when liver is not in your body, you have severe coagulopathy, no synthesis of clotting factor, increased fibrinolysis, risk of hypoglycemia, decrease metabolism of all the drugs and hypocalcemia. You know when liver is not there in your body, what you do. Hemodynamic instability when they cross-clamp the IVC. So the IVC is completely cross-clamped. The volume of blood coming from the lower body is not there. It's zero. The whatever heart is receiving is from the superior vena cava, where it's so the compensatory reaction will be increase in heart rate, that's tachycardia and hypotension. So what we have to do in this situation is fill the patient with IV fluid, give it either gelofussion or albumin or crystolite, fill the patient with IV fluid where BP will tend to increase. At the same time, don't wait for increasing the noradrenaline. Increase the noradrenaline also to maintain a mean pressure of 60. Decrease all the doses of anesthesia infusion. Dextrose as per blood sugar. TEG if you feel the patient is have increased risk of bleeding. Methylprednisolone is given 10 mg per kg as a immunosuppressant during the anhepatic phase before the new liver is put in. Because this is the only immunosuppression used intraoperatively in liver cases. Well, kidney have many other immunosuppression to be used, but liver we use only methylprednisolone. Get a ABG done to see for acidosis, check for calcium, increase oxygenation, decrease air, like on ventilator, what you do? Stop almost all anesthesia agents to avoid any further hypotension. So this is a anepatic phase. What we do, the clamp is on, the BP is 99/52, main pressure are fair enough 7, and you have BIS is there 56/97. So we have stopped a propofol infusion. And here in the SV, you see a SVV of 26. Now, SVV of 26 will prompt everybody to give fluids to this patient. Yes, you do give fluid to this patient, but keep a watch. The IVC is clamped. If suppose you don't know IVC is clamped, you keep on rushing large amount of fluid to decrease this SVV. But on the background of knowledge that you have a IVC clamp, the SVV is going to be high anyway. So you have to balance between noradrenaline and IV fluids in this situation. Now you have post-reperfusion, clamps are opened up and the liver is around 700-800 grams of liver. So 800 ml of blood will directly go in the liver. What you accept is large amount of hypotension in this situation. You have to keep ready. Now, hypotension will be liver is kept in ice before it's been reperfused. Ice along with fluid. The fluid is called as custodial or UW solution. University of Wisconsin solution. It is as good as a cardioplegic solution. What you have used in cardiac, like very high potassium, very high calcium, and all these things. The longer liver remains in this solution, the more problem you see post-operative or post-reperfusion. You see hyperkalemia, you see hypercalcemia, you see arrhythmias, a lot of arrhythmias. You see sudden drop in temperature, you see sudden bleeding. You have to be ready to manage such situations, understanding the amount of cold ischemia that is called. Now, how much time the patient's liver is being kept in the ice. What happens is once they open the clamp, there is decrease in mean arterial pressure, heart rate decreases, SVR suddenly decreases. Cardiac output increases. Arrhythmia might occur because of the large amount of electrolyte solution flushed in the body, which was in the liver. There is high risk of cardiac arrest also if the cold ischemia time is very high and the size of the liver is very big. Volume replacement and increased vasopressin remains your only child. We have gone up to 30 and 40 ml of noradrenaline also. For time being, once the hemodynamic stabilizes, you can reduce your vasopressin. Antiarrhythmic, very routinely used are Xylocard to prevent cardiac irritation. Cordron, not very commonly used. We have used only once till now. But Xylocard and magnesium are we have used electively, empirically to avoid any arrhythmias, and we are safe till now. Coming back to the neohepatic phase, once the liver clamps are open, we ask surgeon to give us 5 or 10 minutes to stabilize all the hemodynamics. The graph turns pink. That indirectly tells you a graph function is good. Stabilization of temperature because livers have picked up. Improvement in the urine output. Normalization of glucose level. Clearance of lactate level happens in next 1 or 2 hours, not immediately. Indirectly tells you liver is picked up. Liver is started functioning. On table you see bile production. That is again a good sign to see whether liver is working well or not. Non-adrenaline requirement goes down over a period of time. The increase in the blood pressure indirectly is a good sign that liver is picking up. So if suppose you see this type of TEG in a post-operative rate, this type of TEG, this is something called the LY30 is very abnormal. Lysis, LY30 means clot lysis at the end of 30 minutes and then LY60 clot lysis at the end of 60 minutes. If you see such type of TEG, any of your practice, the only treatment remains tranexamic acid. There is no other treatment available for this. Now, this is either a secondary fibrinolysis, secondary to coagulopathy, or DIC. Now, DIC, then you have to treat the cause, like sepsis or any other causes of this. Then you have to treat adequately the sepsis. These things improve over a period of time. For this, tranexamic acid remains the best choice for this tech, what we have seen. Neohepatic phase at hepatic artery, after reperfusion, what they do is hepatic artery anastomosis, biliary anastomosis, achievement of all hemostasis, adequate volume and mean arterial pressure to be kept always above 60 in situation. You might require noradrenaline in many situations. But by the end of surgery, noradrenaline goes off. Correction of coagulopathy, now you have to be more meticulous because you have a hepatic artery here, you have a portal anastomosis here. So they have a chances of thrombosis if you give large amount of blood product. So if the drains are okay, avoid treating with a large amount of blood products. If suppose the drains are high, prefer cryoprecipitate than any other products. That will help you, giving you at least 4 to 5 clotting factors and helping you reduce the bleeding. Correction of ABG values, decreasing lactate, improving metabolic acidosis indirectly tells you a good functioning liver. Now you have a ABG here, the lactate has gone down to 3, acidosis is minus 1.9, HB is 11.2, pH has been fine. I'll be loving to extubate this patient on table because everything is settling now. In this situation also, HB was more than 7. We were happy with this and we have extubated this patient on table and shifted this patient to ICU for further observation and management. So coming to the summary, MELD and CTP score should be calculated if you are planning to do a surgery for a patient who is going for any other surgery but having a liver cirrhosis. That indirectly tells you the mortality, anesthesia stress, and surgical cells. Portal hypertension alone is single deciding factor for intra-op hemodynamic status. If you have a very high portal hypertension, the chances of bleeding will be very high. So you have to correct coagulopathy and all these things. Albumin remains your best choice of vasopressor, best choice of colloid when you want to give colloid. Avoid blood products as and when required. Only give if it is strongly indicated. Significant reduction in anesthesia drugs when the patient is in an anhepatic phase or patient is without liver in the body. Avoid large amount of fluid in all patients with liver cirrhosis. Prognosticate the relative well when you are dealing with such patients. Avoid regional anesthesia in patient with child B and C cirrhosis. Child A, you can have a safe usage of regional anesthesia. Thank you.